Throughout the third module, the theme of applying basic nutrition science to the unique needs of athletes has been addressed. The macro and micronutrient recommendations related to endurance athletes, strength and power athletes, and those interested in altering body composition were provided without any distinctions for unique considerations due to age or gender. In this module, recommendations will be made for youth, masters, and female athletes. At the end of this module, you will be able to summarize the nutritional concerns of youth athletes, provide macro and micronutrient recommendations for a youth athlete, summarize the unique nutritional considerations of female athletes, recognize the signs and symptoms of disordered eating, identify conditions that make up the female athlete triad, summarize the nutritional concerns related to masters athletes, and provide macro and micronutrient recommendations for a masters athlete. The majority of research in the area of applied sports nutrition has included a young adult population due to convenience. While this limits the evidence-based recommendations that can be made regarding applied sports nutrition with youth athletes, several primary concerns help guide the practitioner working with this population. The first concern is ensuring the child consumes enough energy to not only support athletic performance, but also normal physiological growth. Childhood and adolescence are times of rapid growth in children, and ample macronutrient intake is required to support it. Another concern for youth athletes are cases of negative body image that lead to disordered eating. The combination of increased demand for energy to support normal growth and athletic performance, and anxiety over body image place some athletes at risk for disordered eating that may severely impact their growth and overall health throughout their life. In addition to consuming adequate fuel to support growth, substantial variety in the food choices youth athletes make will increase the likelihood of meeting micronutrient recommendations. Youth athletes often self-select energy-dense but nutrient-poor food options, which may lead to micronutrient deficiencies in key areas. Finally, ensuring adequate fluid intake is a concern of youth athletes, and they should be encouraged to drink fluids throughout the day to avoid dehydration. Adequate fuel intake not only supports normal growth and development, but also aids youth athletes in recovery between exercise bouts so that the training demands of practices and competitions can be met. Chronic energy deficiencies may delay or prevent the start and maintenance of regular menstrual cycles in adolescent female athletes, as well as delay the recovery from acute and chronic athletic injuries. The energy needs of a youth athlete are based on their current growth rate, their age, their gender, their weight, their height, and their physical activity level. Dietary reference intakes are available for children aged 1 through 18, and they provide a good starting point for recommending daily energy needs. The DRI for energy for a 9 to 13-year-old male is 2,279 kilocalories per day and 2,071 kilocalories per day for a female in this age range. These numbers rise to 3,152 kilocalories per day for males aged 14 to 18 and 2,368 kilocalories per day for females in this age range. Routine medical care for children and adolescents includes following their growth on growth charts, and a child's growth should remain fairly constant in conjunction with the growth chart from the age of 2 through adolescence, regardless of their participation in sport. While puberty is a time of rapid growth and large energy demands, it is also the time when many youth athletes begin considering manipulating their food intake to alter body composition to improve their self-image. Risks of chronic energy deficits include impaired athletic performance, bone development and overall growth, delayed onset of puberty, illness and injury, and the development of a diagnosed eating disorder. Participation in image-conscious sports such as gymnastics, dancing, figure skating, diving, ballet, wrestling, cheerleading, and distance running may predispose an adolescent to disordered eating tendencies, and athletes in these sports should be educated and closely monitored to ensure they are meeting energy demands. Disordered eating is distinct from a diagnosed eating disorder and is defined as a wide range of irregular eating behaviors that do not warrant a diagnosis of a specific eating disorder. The DSM-5 is a resource used by mental health professionals to provide guidelines for the diagnosis of a mental illness. Eating disorders are included in the DSM-5, but disordered eating is not. The Eating Attitudes Test can aid practitioners in identifying athletes at risk of suffering from disordered eating so that a referral to an appropriate healthcare provider can occur. Certain behaviors are indicative of disordered eating and include restricting food intake, binge eating followed by purging, using laxatives, diuretics or diet pills to lose weight, or compulsive exercise beyond that needed to improve at their sport. Symptoms of disordered eating may include dizziness, syncope or fainting, weakness, hair loss, lanugo, which is the development of very thin, soft hair throughout the body, constipation, bloating, abdominal pain, menstrual irregularities, and cold intolerance. As with energy intake, DRI values are also available for carbohydrate and protein intakes in children. The DRI for carbohydrate is 130 grams per day, regardless of age, with an acceptable macronutrient distribution range, or AMDR, of 45 to 65% of total calories coming from carbohydrate. The DRI may underestimate carbohydrate needs of pubertal athletes, and the AMDR may provide a better guideline. The DRI for protein increases from 13 grams a day for ages 1 to 3 to 46 grams per day to ages 14 through 18. However, the AMDR for protein is 10 to 30% of total calories coming from protein, and a relative recommendation of 1.5 grams per kilogram of protein per day in pubertal athletes serves as a good recommendation to ensure adequate support of growth and development. Recall from Module 2.4 that the micronutrient intakes of athletes are not greater than those of non-athletes, and this holds true for youth athletes. Concern regarding micronutrient intake is centered on consumption of nutrient-poor foods, so a multivitamin is recommended for days when nutrient density is low. Important micronutrients that stand out in adult athletes also warrant special attention in youth athletes. The adequate intake for calcium is 1,300 milligrams per day for children aged 9 to 18, and it is important to note that bone mineral density increases by the largest amount during adolescence as compared to the rest of life. The RDA for iron in children ages 9 to 18 is 8 to 15 milligrams per day and will support the supply of oxygen to contracting skeletal muscle. Children are capable of dissipating heat to the same degree as adults due to lower sweat rates. The greater surface area of a child, relative to their body mass, allows for more heat gain from the environment and adds to the problem. Therefore, children are at an increased risk of developing a heat illness, and hydration may play a role in minimizing this risk. Fortunately, the fluid recommendations for youth athletes are the same as adults. Children should weigh themselves before and after exercise and consume 24 ounces of fluid for every 1 pound of body weight lost prior to beginning the next exercise session. They should also drink 4 to 6 ounces of cold water every 10 to 15 minutes during exercise, preferably from a sports drink including sodium. Cold beverages and those containing sodium promote greater fluid consumption. Frequent breaks should be provided every 15 minutes with children moved to a shaded area during this time if possible. The unique sports nutrition concerns of female athletes were introduced in Module 3.1. Recall that the micronutrients calcium and iron stand out as important considerations of female athletes due to their role in bone health and oxygen transport, respectively. The adequate intake of calcium for premenopausal adult women is 1,200 milligrams per day and raises to 1,500 milligrams per day during pregnancy and lactation. Iron intake may be low in female athletes due to low consumption of meat. The RDA for iron is 18 milligrams per day and rises to 27 milligrams per day during pregnancy. Chronically low iron levels can lead to anemia and a lack of oxygen being delivered to working muscle. This may increase the perception of exercise at any given intensity. A common concern regarding female athletes, both youth and adult, is the development of the female athlete triad. This phrase describes the combination of disordered eating, the amenorrhea that may result from excessive exercise and disordered eating, and the osteoporosis that may develop from the disordered eating and amenorrhea. Poor energy intake from disordered eating habits, coupled with micronutrient deficiencies, decreases bone mineral density, while a low percentage of body fat stops the menstrual cycle. The combination may lead to osteoporosis and the increased risk of bone fractures associated with it. The same sports described earlier that are susceptible to disordered eating habits include athletes that may be more likely to develop the female athlete triad. Deliberate caloric restriction coupled with a lack of awareness of the energy intakes required to meet the high demands of high intensity exercise are signs of the female athlete triad. The following factors may contribute to the development of disordered eating in either youth or adult athletes. Coaches that promote nutrition myths and misconceptions often have large influence over their athletes. The weight requirements of the sport and its emphasis on a certain body size may influence eating habits. Athletes may have daily schedules that do not leave ample time to eat all of the energy required each day. Athletes may have misconceptions about what strategies maximize their chances of performing well in a sport, and some are extreme thinkers who are hard to convince otherwise. Young athletes often have a general misconception about human physiology as well. Body consciousness occurs at a pivotal time in female growth and development, and a culture's portrayal of female athletes as sex symbols may influence eating behavior. Finally, devastating or career-ending injuries may generate sufficient psychological trauma that manifests as disordered eating. Like all sports, adequate energy intake is a concern for masters athletes. The masters athlete has been defined as a competitive athlete over the age of 35. As age increases, so too does the loss of skeletal muscle mass known as sarcopenia. As more muscle is lost, less energy is required to fuel the remaining muscle. Resistance training may help masters athletes maintain skeletal muscle mass longer in life, and it is important to note that adaptations to resistance training can occur at any age. The Harris-Benedict equation is appropriate to estimate resting metabolic rates, and including a physical activity factor will provide a good estimate of total energy expenditure per day. While the RDA for protein of 0.8 grams per kilogram has been shown to maintain muscle mass in older subjects engaged in resistance training, it is important to note that decreases in total energy intake as one ages may drop protein intake below the RDA. Masters athletes should be encouraged to consume at least 0.8 grams per kilogram of protein per day, but the increased protein recommendations discussed in Module 3.1 and 3.2 may produce a greater ergogenic effect. Like all athletes, care should be taken by masters athletes to consume enough calcium to support bone mineral density. The adequate intake of calcium for adults over 50 years old is 1,200 milligrams per day. Consumption of vitamin D should also be monitored if a masters athlete has limited exposure to sunlight. The RDA for vitamin D is 400 international units in men and 600 international units in women over 50 years old. Masters athletes may develop a diminished thirst sensation due to a decrease in total blood volume, a reduction of water retention at the kidneys, and disturbances in the balance of sodium in the body. Common fluid intake recommendations are sufficient to meet fluid needs, but masters athletes may need reminders and encouragement to drink more fluids before, during, and after exercise if their thirst sensation is diminished.